Hi, Dr. Nathan. I think you're muted.
Hear me?
Yes, I can.
Okay, I think I can share my slides now.
Oh, lovely. Please go ahead. Okay. I think we can get started by 6:05. Just 30 seconds
Okay,
to go.
okay.
Okay. Hi, everyone. My name is Shola Ladeji, and I'd like to welcome you all to this first session of our arthroplasty lecture series. And we'll have the pleasure of having Dr. Nathan, who is an orthopedic surgeon at Coptic Hospital, Lagos, to get us started on total knee arthroplasty. Please go ahead, Dr. Nathan.
Hello, good evening, everybody. I have the pleasure to join you today. I'm Dr. Nathan. I'm orthopedic surgeon from Coptic Hospital, Lagos. And I'm going today to have a short speech and in simple terms about total knee arthroplasty or total knee replacement. Is that okay? Is okay? Shall I start now?
Yes, it is. If you could just have your slides on slide share.
Okay. Is it now shared? Uh,
Um, if you click on the slideshow icon,
back. Is it shared now? I hope it can be shared.
I think you may have discontinued. I think you may have stopped slide share. Fine. So
So
we
so
can see your
is
screen
it
now. So if you just click, yes, it is. If you just click on the slideshow icon,
okay?
that's
Is it
just
sh- is it
at the
working
right
now?
bottom. Maybe if you move your screen, let's see if
What should I do? I'm sorry.
So if you look at the bottom of your screen towards the right, and
Okay.
just to the immediate left of the icon showing like a positive and negative pole, an horizontal line. You see an
Okay.
icon that looks like a TV on a stand.
Uh,
If you put your cursor right over it, it pops up with a slideshow.
so it's not shared now. The total knee or the slide now is not shared with you.
It is just that
So
if you
to
try
make it
to
full
move
screen,
it.
you mean?
Sorry.
To make it a full screen?
Exactly. And
Okay. So
slideshow makes it easy for you to move as well.
um, so when I share screen with, I choose the Windows and choose the PowerPoint and share.
Yeah.
So
So
what should I do next?
okay. So the right option to choose when you try to share your screen is the one that says your full screen.
Okay.
So it pops up with a few
I'm
options. If you click on the option that says window, you won't be able to proceed with the slideshow. But the one you need to select is your screen itself. So you have to share your
okay.
entire screen and then go on to the
Okay.
slides. And by doing that, you'll be able to proceed
Is it fine now?
and get a slideshow home. Yeah, so if you
Okay, I
click on
did.
your slides now, yes, and you click on the
Okay.
slideshow function.
Is it working now?
Wonderful.
Is it okay now? So shall I
Yes, we
start
can.
now?
Yeah, I think we can move on from here.
Is it clear now with you?
Yes, it is.
Okay. Okay, so let's start. Okay. So now we are going to speak about total knee arthroplasty, which is in short term we can call it TKA. So we have some items to share today. We have some short introduction, and then we have 5 items to speak about. We will speak about indications of total knee and main principles for successful TKA, and also we will speak possible complications and how to prevent, and rehabilitation, which is very important after the operation, and then we will finish by some common questions. So let's start with introduction. What is total knee arthroplasty? It's a replacement of the extremely painful and arthritic articular surfaces. So please look here at these 2 pictures. On the picture on the left side, we have 4 knees. The very left is the normal knee, with articular surface is smooth and covered with nice cartilage layer. With some osteoarthritis, it becomes the next knee on the right side. And then the third knee has a severe osteoarthritis. We can see rough surface, and this is very painful to use while walking. That's why we can do what's called knee arthroplasty to remove this rough surfaces and use a new artificial smooth surfaces as on the fourth knee. So on the other photo, we can see some components of the knee replacement. We cut this rough surfaces of the knee, of the tibia and femur, and we put these 3 components, the tibial component and the femoral component or coverage, and in between there is what's called an insert. It's just a smooth surface between 2 surfaces. So this is a simple picture of what is a knee arthroplasty. Uh, we want to speak about what is the goal for knee arthroplasty. Why we do this operation? We want to get a new, near more or less natural knee, very anatomical, and also with pain-free. I mean, the patient can move freely after the operation without pain. And we have two more goals for this operation. To have a stable knee. Stable knee means the patient can walk and run with the patient while walking and running. And regarding longevity, it means that it can long last. We know that osteoarthritis, all the knee become aged. So we have to choose a new knee that can long last for many years, that we will not need to change it another time shortly. So longevity is one of our main goals for total knee arthroplasty. As you can see in this picture, this is total knee in brief with the three components of the knee. Well, now we want to speak about how frequent do you think total knee arthroplasty is performed? So I don't want to put a lot of numbers, but I can take a USA as an example. So you have to know that about 1 million total knee arthroplasty procedures are performed in USA every year, and it's expected to be much more higher than this by 2030. So simply, I want to draw the attention for the difference between two kinds of knee arthroplasty. When we say total knee arthroplasty, we mean the one on the right side. But there is another knee arthroplasty, which is called unicompartmental or unicompartment knee arthroplasty, where we can change only one compartment of the knee. You have to know that the knee has three compartments: medial compartment, and lateral compartment, and patellofemoral compartment. So total knee is changing almost the three side compartments, but there is also what's called the unicompartment to change only the medial side of the knee. Let's start with the first item, which is indication criteria for total knee. Which patient I can choose to have this major operation? Any patient with knee pain? No. We have some criteria. The patient must have a pain with arthritic joint, and this pain must be not less than 3 to 6 months, with intermittent or many times a week pain or constant pain. Uh, and also, the patient must have severe arthritis confirmed by X-ray or radiological imaging, and also confirmed clinically. The patient must be old, because we know that the new knee has longevity, as we mentioned. It has like from 15 to 30 years age. So we cannot do this operation like in 20 or 30s or 40s. Usually this operation not be done before 55 years old, and in some countries not before 60. The patient must have a problem with the quality of life for at least 3 to 6 years to be chosen to have this operation. And also we have to try all kinds of conservative measures, which include medical treatment, anti-inflammatory and muscle relaxants, and local application of various kinds of modalities. The patient must have physiotherapy and routine exercises for his knee to strengthen the knee. Uh, we can try all conservative measures. After failure of all of that, we can resort to our last resort, which is total knee arthroplasty. Also, one of the indications is deformity, especially genu-varum, with the knee deformity, especially genu-varum and sometimes genu-valgus. And also, and sometimes it's indicated for revision of total knee replacement or total knee arthroplasty. So we can have like pictures of patients with knee pain or knee arthroplasty. It's old age with arthritic joint and long-term suffering. And in the right lower side of the screen, you can find a genoverum of both sides of the knee. Well, now let's have a look about what are the contraindications, situations that we will never do total knee arthroplasty. The most important thing that prevent us from making this operation is infection. Infection of the knee is absolute contraindication to have an artificial object to insert it inside our body. So whether the infection is current, the patient has now an infection, or he has recently an infection of this joint, or even if the patient has an infection elsewhere in his body, like recurrent urinary tract infection, we cannot do total knee arthroplasty at the moment. We have to treat any infection first before we proceed to total knee arthroplasty. Also, we will not do total knee arthroplasty in a patient with a lower limb neurological problem, like any paralysis or any weakness or any even other concomitant problem like sciatica or something else. We cannot do total knee. We have to treat that first if it's treatable. Also, we cannot do total knee arthroplasty with a patient with extensor mechanism dysfunction. Extensor mechanism, you have to know this is very important to everyone. We cannot stand up without that. We cannot walk or run without extensor mechanism. What is it? It's quadriceps together with patella and patellar tendon. This is responsible for extension of the knee. It is very important for you to stand up, to walk, and to run. So if a patient has a problem with this extensor mechanism, he cannot have this operation be done. Also, we have to check ipsilateral hip. If the patient has a problem with right knee, his right hip must be fine so that he can have proper rehabilitation after the operation. If he has osteoarthritis of the hip, it must be treated first. So osteoarthritic lateral hip is a contraindication to have a total knee arthroplasty. Also, relative contraindication. These are absolute contraindications, but there are some relative contraindications, including if the patient has general well-being, general medical problem like anything interferes with anesthesia, so it must be treated first. Any metabolic problems that affect the wound healing, like uncontrolled diabetes or something like that, it can be considered a relative contraindication. Also, some other conditions like atherosclerosis of the same lower limb, it will affect the circulation of this lower limb. If there is venous stasis, it will put a patient at high risk for DVT, which is very problem for him. Also, if there is another infection like cellulitis, look at this picture. This patient has a problem with his right lower limb. We cannot do this operation for a limb like that because of infection, because of venous stasis, because of inadequate blood circulation, because this could have a neurogenic problem. Also, one of the relative contraindication is obesity. Sober obesity, like body mass index above 50, is contraindication to have this knee because the new knee may be unable to weight bear this overweight. Also, any recurrent infection like urinary tract infection. Well, now we can proceed to our second part of this lecture, which is 6 main principles for successful total knee arthroplasty. I know not all of you are orthopedic doctors, so I will have just general look over these principles just to have an idea. In orthopedic, we have something called biomechanics of the lower limbs. Like axis of the lower limb is different between anatomical axis and mechanical axis. So we have some important principles, including like first one, alignment of the tibia. The tibial cut must be completely perpendicular with the mechanical axis. What is the mechanical axis? you can understand it is the axis of the tibia, or the line over the bone marrow of the tibia. Also, it has to be 3-degree posterior slope. You know, the tibia, the proximal end is not horizontal. It has a posterior slope 3 degrees. And also, the resection must be between 8 to 10 millimeter. We will know that later on about this resection amount. The second principle is alignment of the femur. You know, the two condyles of the femur posteriorly, they are not the same line. If you can look at this picture on the lower at the left side, the medial condyle is prominent more than the lateral condyle. So we have to do the distal cut. You know, to understand this operation, we have 3 important cuts. The tibial cut, you can understand it. We cut the tibia proximally, horizontally. And we have 2 other important cuts. The femur distal cut and the femur posterior cut. So if we look at this picture, when we cut the femur, it has to be in valgus 5 to 7 degrees. Why? Because if you look at the right side picture, you will find the femur has 2 axes. One axis, which is called anatomical axis, it's along the bone of the femur, along the medulla. And there is also mechanical axis. Mechanical axis is the axis that carries our body weight. It's from the center of the head of femur to the center of the knee. So there are 6 degrees between these 2 axes. So we have to make the total knee in valgus from 5 to 7 degrees. Usually it is 6 degrees, but sometimes it's different from person to person. Also, we have to do some external rotation, about 3 degrees, and also the resection typically is between 8 to 10 millimeters. Sometimes it can be, we can have 2 more millimeters if it's PCL sacrifice. So this is the second principle. Third one is medial and lateral balance. Look at this picture. Look at this picture. You have medial and lateral collateral ligaments, which are responsible for the balance of the knee while walking and standing. So while we are doing this operation, we have to make sure that the medial side and lateral side are equally balanced. So I know you are a doctor and you can think about different cases, like if the patient has a valgus or varus before the operation. So at that time, we have to do some interventions to make this balance. Sometimes we need to do a release of some ligaments, and sometimes we have to do interventions to tighten these ligaments. But the basic idea, you have to know that in this operation, we depend on these medial and lateral ligaments to give us some balance, and we have to check that intraoperatively. Fourth principle is flexion and extension gaps. If you get this principle, I suppose you now are understanding this operation. As I told you, there are 3 cuts. The tibial cut, as you see, it's the cut of the tibia. And the femur has mainly 2 major cuts. The distal cut, which you can see on the right photo of the femur, it is the distal end of the femur. And the other one is posterior cut, which we use on flexion of the knee. So between the distal cut of the femur and the tibial cut, this is extension gap. It is the gap between femur and tibia while the limb is extended fully. But the other gap is flexion gap. Flexion gap is the gap between femur and tibia while the knee is 90 degrees flexed. So this gap is flexion gap. So which gap is important for us? Extension gap or flexion gap? What do you think? The patient uses the extension gap while he is walking, and flexion gap while he is climbing stairs, for example, or sitting down. So both gaps are extremely important. And interoperatively, we have to make sure that both flexion gap and extension gaps are perfectly equal to each other. So the fifth principle is patellar tracking. But you know that the patella has a track at the end of the femur. As you see in this picture, there is a track for the patella to run in while flexion and extension of the knee. The patella must be centralized on this gap, on this track. So in many cases, the patella is shifted to one side. Like, look at the arrow, it points to the patella shifted, usually to the lateral side or outer side of the knee. This is a very big problem, and we can have a very successful operation, but later on the patient suffers of pain anteriorly because the patella is not centralized in its track. So the patella must be tracked, and it's called thumbless. It means you don't have to support the patella to be in its track. So you have to check that interoperatively, and also if there is any maltracking, you have to fix that. And also rotation of the tibial cut can affect the Q angle of the extensor mechanism, which can lead to patellar maltracking. So that you have to make sure that you have proper but tibial cut, and also you have to make sure that the patella is properly tracking in place. I know some of you haven't seen a total knee arthroplasty before, so I want to explain something to you. Interoperatively, after we have these cuts are done, we put a trial. It is very similar to the final implant or components, the same size, identical in everything, but it's not the final totally. So we put this trial and we check all of these principles. Before we put the final knee, we have to make sure these principles are fulfilled, and like all flexion extension gaps are equal, medial lateral are equal, all cuts are perfect, and also the patella is in place. Last principle is low contact stress. You know, total knee currently is different from the total knee like 10 or 15 years ago. We have currently modern knee. Look at these two pictures. The first, on the left side one, there is a small contact between the femur and the tibia. And the one on the right side, it's curved, the insert. This white piece is called insert. It's like a plastic, special type of plastic. You can see now a large area of contact. So when we have large area of contact, we have low contact stress and we have high constraint forces. But the picture on the left side, we have low contact area with high contact stress. It means all the body weight are transmitted to tibia through only this small contact area with low constraint forces. So what do you think? Which knee is better? Yeah, I'm sure most of you are saying the right one. So this is one of the successful knees to have a high contact area with low contact stress. Why? Because on the long run, after many years, if you check both knees, the right one will have less wearing, it will be less torn up, but the left one will be overused, and the insert will be like eaten up with frequent use of this knee. So now I can move to the third part, which is possible complications. What are the possible complications of the total knee? This is a very important point because there are especially two complications that are like a nightmares for any doctor, which are infection and DVT. Uh, you have to know that they are not frequent. Like infection is less than 1%, 1 to 2%. Some centers is less than 1%, and some centers are 1 to 2. But generally speaking, this is not high. And also DVT currently is not high. So, but generally speaking, we have to give the extremist attention to prevent these two complications. How to prevent infection? It's easy. Strict adherence to aseptic technique. Some operation rooms we prefer like vertical laminar flow with air coming up, down, uh, and distributed to the sides. It's better than the horizontal laminar flow. And also, everyone can know about aseptic technique, but we have to be 100% committed to this. Also, we have to early diagnose infection if happen. So how to diagnose? It's easy, especially laboratory findings, total leukocytic counts, ESR, and the most reliable one is CRP. Also, cardinal signs like swelling or erythema or redness, etc. And also, the most confirmatory test is aspiration and SINTO analysis. If you diagnosed early, you can treat early, but it's better from treatment to avoid infection. The other important complication is DVT. Uh, Before you read this slide, if we have 100 patients with total knee arthroplasty without prophylaxis from DVT, how many of them do you expect they will develop DVT? 10%? More. It's about 40 to 84% without prophylaxis will develop DVT. So to prevent DVT is extremely important. You have to start on anticoagulant, chemical anticoagulant, 6 to 8 hours post-operatively. Never forget to give DVT prophylaxis as soon as possible after the operation. You can give low molecular weight heparin, you can give XC inhibitor, which is very common to use nowadays. Aspirin can be used, warfarin can be used, but any of them must be used 6 hours 6 to 8 hours operatively. Also, there are mechanical prophylaxis like applying stockings, applying food pumps. There are many local, I mean, in the lower limbs, prophylaxis from DVT. Uh, some other possible complications include fracture. Many times during the operation, or not many times, but sometimes interoperatively, fracture can happen like pre-prosthetic in the femur or tibial fractures. If you are careful, this fortunately cannot happen. And also, it has very low incidence. I remember from 0.5, 0.5% could be the fracture incidence. Also, popliteal artery injury has a low incidence of happening. Patellar tendon injury or quadriceps, which we have spoke about, the extensor mechanism is very important to keep in place during the operation. There is something called patellar syndrome. This is like a soft tissue nodule formation, like a ball of soft tissue in front of the knee above the femoral insert. It can be like a lever over the extensor mechanism. It will be very painful, but it's easy to treat. We can treat it arthroscopically, and to remove it, it's not a big problem, but we have to prevent it intraoperatively. Very rare to happen peroneal nerve palsy, especially while treating a valgus patient. Stiffness, if there is less rehabilitation post-operatively, the patient can suffer of stiffness. with decreased range of motion of the knee. Pain post-operatively has many possible causes and also sometimes happening loosening of the components, either femoral or tibial or patellar. Now we can proceed to the fourth part of our lecture, which is rehabilitation. We have two items to speak in rehabilitation. What about the significance of rehabilitation? Uh, Unfortunately, all over the world, many people are very focusing on the operation itself, the surgeon, the hospital, the company, and all of that. But it is very, very important to focus on rehabilitation. It is as important as the surgery itself. If you have a perfect operation with poor rehabilitation, this definitely will lead to very poor outcome. So rehabilitation after the operation is extremely important. So what can we do in rehabilitation? We have a goal to restore the range of motion of the knee from 0 to 120. And the minimum range accepted is 5 to 90 in some stiff knees. Uh, we need to afford the patient full function of the knee by 12 weeks. So we ask the patient never put a pillow under the knee and leave the knee flexed for a long time, and never stay in recliner for a long time, especially during sleep. So movement of the knee after operation, you can know now, is extremely important. Leaving the knee without movement after the operation is extremely harmful. So I can simply speak about three phases of rehabilitation from day one post op after the operation to day three. There is what's called continuous passive motion. It is a machine. The patient can put his lower limb over and it can move the lower limb according to the range we detect. So usually during the first 3 days, it's between 0 to 90. The patient is not actively moving the lower limb, but the machine itself moves the lower limb to flex the knee and extend the knee. This is during the first 3 days. The patient can apply some ice. I know there are some dressing, so maybe good to do that a little bit later. To control the pain is very important, and also to strengthen the hip and ankle muscles during this time is very important. Also, this mobilization is very important to prevent one of the nightmares, which is DVT. Why DVT is nightmare? Because it can lead to pulmonary embolism, which is a risk for the life of the patient. So, if we left the patient without movement, I put the patient at high risk for DVT and pulmonary embolism. So, I have few minutes left. So, from day one to day three, continuous passive motion. From day 4 to 4 week, we have to prioritize stretching of the muscles and help the patient to straight leg the raising test, help the knee to elevate the lower limb like that by himself or herself. And from week 4 to week 12, we have to recreate athlete. We have to strengthen the muscles fully. We have to restore the muscle power of quadriceps to 95%. The patient has to do some resistive exercises to strengthen the muscles. So now I finish with some common questions. When walking post-operatively, when the patient can walk after the operation, hopefully from the first day, we encourage the patient as he can, as tolerable he can wait, like he can wait there from the first or second day, according to the physiotherapy management. How long does the operation take? It takes 2 to 3 hours usually. The hospital stay usually it is 3 days. Sometimes we have to uh, uh, full recovery happening, and the patient can manage few steps by himself or herself, or and can step up and down few steps of the stairs. So the hospital stay it could be 3 days more or less. What time he can go to work back to work, like usually 2 weeks to 5 to 4 weeks according to the nature of the work. When can you drive? Usually we have to keep safety of the patient, so driving it can be delayed like 4 to 4 weeks. Swimming by 3 months, the patient is able to swim, supposed to be, uh, and traveling also supposed to be at 3 months. The patient is able to move and by himself without any support, without any crutch or stick. So this is the most common questions. Uh, Finally, I want to give final messages to any orthopedic doctor there. First advice: be a healer. You treat a human patient, not an X-ray. Second one: practice mental jogging before the operation. Every time you are going to an operation, think about, imagine it, do the operation in your mind before you do it in the operation field. The third message: orthopedic surgeon is an artist, not a carpenter. Do everything meticulously. Look at things in 3 dimensions. And you have not to miss this advice. Measure twice and cut once. Some surgeons cut and then cut again and then correct the cut. But no, make a good measurement. Take your time and then make one correct cut. And the last advice, you have to remember that total knee arthroplasty is a soft tissue surgery with some bone cuts. Don't focus very much over the cuts and neglect the soft tissues of the knee because it's very important for the outcome of the knee. Thank you.
Thank you very much, Dr. Nathan. I think it's been a very delightful session.
Thank you. My pleasure.
I think I quite enjoyed every bit of it, from the dense academic to the technical content. I think it's even a very practical one, and obviously the rehabilitation, which is quite key, where
Yeah, thank you.
junior doctors especially get involved in the care on the ward. And I think those are very important points that you've raised. And of course, the last bit, I think the one I found quite a bit amusing, but I think is quite instructive. I mean, the caveat that orthopedic surgeons are artists and not carpenters, which is a popular parlance. I think
Yeah,
that's a very important thing to highlight. Thank you very much for that wonderful session.
thank you.
I would welcome questions now. If anybody has a question, if you could kindly raise your hand, and we'll take the questions one after the other. You could also drop your questions in the chat section if you prefer. I think there are no hands. There are no hands yet. I think while hanging around for a bit, um, I'm happy to maybe take the first shot with the questions. Dr. Nathan, your experience with total knee arthroplasty in Nigeria. I mean, we've talked about the technical aspects of the procedure. What's your experience in terms of the financial aspect? I know my experience back home. There are quite loads of people with that are struggling with very severe osteoarthritis, and they just don't have the financial wherewithal to, I mean, pay for this service. And again, it's probably not a very common service in a lot of public hospitals. You tend to have arthroplasty surgeries generally done mostly in private sector. In Nigeria, obviously it's now gaining more traction and more momentum in government hospitals as well, but it still remains expensive in my experience. What has been your experience, Dr. Nathan?
Well, unfortunately, I don't have a long time experience in Nigeria for surgeries, so I cannot give you meticulous information about that. But I can say, apart from the insurance companies which are supporting this operation, some hospitals can afford this operation with could be affordable prices. So if we can take only the price for the components itself from the company and reasonable for the anesthesia and the hospital, it will not be like extremely expensive like it is in very
Lovely. Thank you for that. Well, so far there are no hands up for questions, and there are no questions in the chat log. I guess if we don't have any questions, I wouldn't want to keep you around any longer. Once again, Dr. Nathan, thank you so much for gracing
oh,
us
it's my pleasure.
with your presence, and I mean, we'll be reaching out to you for some other lovely sessions in the future. I hope you'll be glad to.
It will be my pleasure.
Thank you so much.
Thank
So,
you.
everyone, the feedback forms will be rolled out shortly. Kindly take a few moments to fill the feedback forms. They're going to be very helpful for us in terms of planning these sessions in the future, and obviously to also give the speaker some feedback in terms of how the session went. So I want to thank you all for attending this session. Have a wonderful rest of your evening.